Good morning and welcome to Living Sickle Smart with Sickle Cell Foundation of Minnesota. We are so pleased to be back again and have two guests as we continue in our series, Sickle Cell Disease, a Public Health Emergency. And for today's session, we have two very special guests who are representing the Sickle Cell Disease Association of America. We have the president of SCDAA, Beverley Francis-Gibson, and we have the chair of the Medical Advisory Committee, Dr. Louis Sue, out of Chicago, Illinois. And so without further ado, we want to hear from them. We want to better understand what we are working on from a national perspective and how the CDC data collection and surveillance project is benefiting the sickle cell community. So first and foremost, Ms. Beverley, I will have you begin.
Thank you, Ray. Good morning, everyone. I am going to share my screen. And I want to just thank Ray for this opportunity to give you some highlights and some information about the Sickle Cell Disease Association of America. The Sickle Cell Disease Association of America serves as the nation's only volunteer organization working full-time on a national level to resolve issues surrounding sickle cell disease. Our mission is to advocate for people affected by sickle cell disease conditions, empower community-based organizations to maximize quality of life, and raise public consciousness while advancing the search for a universal cure. We work in partnership with 53 community-based organizations designed to serve individuals and families in their local communities. Our member organizations, as they're affectionately known, assist individuals and families with finding quality health care. They maintain databases of individuals and families that they have served over many years. They provide community outreach, and they educate their local communities about sickle cell disease and sickle cell trait. Our members are classified in three categories: direct patient care services, support services, and advocacy services. Now, this does not mean that a member organization cannot provide all three, but we ask them to self-identify which service they most affiliate with. During the COVID pandemic last year, we announced an emergency fund to assist individuals and their families. The fund was planned to raise about $100,000 in 10 days. And I'm happy to report that over the course of several weeks, the community came together, individuals, companies, businesses, civic groups, and they donated over $300,000, which SCDAA provided and in the form of mini grants to our member organizations. This money was used by individuals to assist with water, food. We assisted with childcare, rent, basic necessities, and medical supplies. I am not going to talk about our research and Medical and Research Advisory Committee because Dr. Sue is going to talk about that committee and the tremendous work that they did and they're continuing to do to serve the community. But I did want to mention that our committee was meeting weekly to address issues dealing with the COVID vaccine and the COVID pandemic. Currently, SCDAA has a few initiatives that I just want you to be aware of. And so we are very focused on raising awareness about sickle cell disease and sickle cell trait. And we do that through a number of outreach efforts throughout the United States. We also announced this year our legislative advocacy agenda, and I will share with you what those 7 priorities are in a few minutes. We also provide monthly capacity building opportunities and trainings for our member organizations, and those are called leadership academies. And we have a number of partnerships and collaborations that help us further our mission. We also work with the pharmaceutical industry to ensure that the patient community is informed and educated about treatments and research that is available, as well as clinical trials. A number of activities that we provide throughout the year, as I mentioned, one is our Leadership Academy, which is a monthly capacity building and program training for our member organizations. We also have been training community health workers for quite some time, and I am proud to share that we now have an online portal for anyone who would like to be trained as a community health worker. To date, we've trained over 150 community health workers across the country, and they're providing vital services to individuals living with sickle cell disease and their families. We also announced our Power Project, which is based on the ECHO model, and it helps our community health workers to come together every month around a particular topic and discuss issues that are relevant to what cases that they're seeing on the ground. We also announced our peer-to-peer mentoring program, which is a program for anyone transitioning from adolescent to adults. And we have 12 mentors and mentees that have been matched through this program in 2020. Additionally, our National Sickle Cell Advocacy Network was relaunched in April at our Advocacy Day. SCDAA has been very involved in helping to ensure that our legislative advocacy has resulted in bills being passed in Washington, D.C. And the reauthorization of the Sickle Cell Treatment Act companion bill was passed. And this is something that our member orgs, our partners, our stakeholders, our families, caregivers, and individuals living with sickle cell disease worked on tirelessly for several years to see this legislation actually enacted. I mentioned previously that we announced our legislative advocacy priorities this year, and here are the 7 priorities. I am not going to read them to you, but I just wanted to emphasize that we are very focused on ensuring that there is money available for research, medical research, that there is additional treatments and innovative therapies that are available for our patients, and that we are part of meaningful dialogues, not only in Washington, but with partner organizations at the federal and state levels. We also want to support public health programs that provide a specific benefit to our community. We want to be a part of addressing the coverage and access issues that challenge community access to comprehensive, affordable, and quality healthcare. And we also want to be a part of meaningful conversations to encourage the federal and community partners to talk about what is available for our community. We also want to ensure that there is a nationwide grassroots network of volunteer advocates that are capable of effectively carrying legislative and policy messages to legislators and representatives at not only the state, but at the federal level. And then lastly, we want to build on a critical mass of support on the Hill so that we can continue to advance our legislative agenda and priorities on an annual basis. In addition, SCDAA is very involved in ensuring that the community understands what clinical trials are and where they are available. And if they would like to get involved, we help to encourage participation. We also are very involved in ensuring that there is education about bone marrow donations and how that could be accessed through a partnership with Be the Match. We also are partnering with the National Red Cross and American Blood Centers to ensure that we are encouraging blood donations, particularly now during COVID, because there has been a blood shortage throughout the country. We're also helping to educate on hydroxyurea education throughout the country. And our CMO, Dr. Sue, is one of the people that has done an amazing job in providing this education through webinars and other trainings, not only to our CBOs, but to the CHW community, to patients, and to their families. And as I mentioned, our national public awareness campaigns that are geared to help raise awareness about the needs of our community. I am very proud to say that we completed a HRSA newborn screening grant that provided the opportunity for SCDAA to establish a national infrastructure that helped families find resources, follow-up services, counseling, receive educational materials, and access to medical homes as needed. We also, I have to mention our Get Connected patient-powered registry, which to date has about 6,100 individuals registered in this registry. It was established as a network for families, particularly children and adults living with sickle cell disease, so that they could provide up-to-date information about their medical care. This registry also gives them an opportunity to see and read about updated research and clinical trials that are happening across the country, and to establish a network to support clinical research through community-based navigators. This year, we also worked with oneSCDvoice to seamlessly integrate Get Connected and oneSCDvoice. oneSCDvoice is a curated library, digital library that provides information on sickle cell disease research to our community. And so we encourage you to sign up for either Get Connected or oneSCDvoice. There is no cost to do this, and it gives you an opportunity to stay plugged in and stay in tune with recent information and resources. I often mention that SCDAA cannot do the work that we do alone, and nor do we want to. We believe that it is important for us to build relationships and partnerships throughout the country, and that by doing so, we help to leverage the needs of not only our organizations, but the community. And so one of the roles that we play is that we can be an influencer, we can serve as a convener, we can help to elevate the message of sickle cell awareness and sickle cell trait. We can help to educate our communities and individuals and families that are typically looking for resources in their areas, and connect them to member organizations locally. And then we participate on a number of coalitions and boards and meetings that help to further our mission and expand information about sickle cell disease. And I also just want to share again, clinical research has had its challenges throughout the year, through to a lot of historical events, and SCDA is playing its part to help to alleviate and to correct some of that information, and to ensure that people know what they're getting involved in prior to signing up for a clinical trial. We are also partnering with a number of patient groups, other patient groups across the country, and I should add globally, because we all recognize that sickle cell disease is not a disease that's just a domestic issue here in the country. And lastly, what I would like to state is that we all have to work together, and we all can do so if we come together to effectively ensure that there's access to care and quality treatment and new therapies for our families and individuals. That if we work together to increase clinical trial participation, increase awareness about sickle cell disease and sickle cell trait, ultimately, we build stronger coalitions and alliances to finding a universal cure for sickle cell disease. And I just wanted to list the number of events that we've hosted this year. And September is National Sickle Cell Awareness Month. We have a number of events that our member organizations have planned, and we're encouraging you to take advantage of those and tell your friends and families and colleagues about that. Additionally, SCDAA is planning and has planned our annual convention, which will be held October 12th to the 16th, and we're inviting you to all participate in that virtually. Lastly, with all of the social ills that are afflicting our nation today, we are living through some very challenging times. And it is my hope that the people who attend this meeting come away with a willingness to come together to find solutions for the sickle cell community. And I do believe that we can do it, and we can do it together. And I thank you. At this time, I would like to turn the presentation over to Dr. Louis Su, CMO of SCDAA.
Hey, thank you, Beverly. And thank you, Ray, for having me. I'm the Chief Medical Officer for Sickle Cell Disease Association of America. It's a volunteer gig. My day job is pediatric hematologist at University of Illinois, Chicago, taking care of patients, doing research, doing education. And so this is pretty much taking the volunteer hat, Chief Medical Officer. I'd like to get my slides up here. Great. And so the Medical and Research Advisory Committee is part of the Sickle Cell Disease Association of America, trying to serve as advisors, basically, for the community of patients, of community organizations. And so here is the list of who is on the Medical and Research Advisory Committee, which I'm going to call MARAC from now on. 34 volunteers. You can see all the names here. And if you read quickly, you can kind of see some of these characteristics of this group, but I'm going to just jump you through those real quick here. Next slide. That there are an equal number of males and females. There's mostly physicians, but there's also some psychologists, nurse practitioner. It's almost equally split between people who are pediatric sickle cell experts and people who are adult or lifespan approach. So it's not all just for the kids like me. It's mostly US, but there's a lot of people from other places too. So there's from Canada, from Lebanon, from Italy, from United Kingdom, from Tanzania, from Ghana. And so there's a broad range of perspectives from many of the different places where there are individuals with sickle cell disease across the world. Different ages, different discipline perspectives. And across the US, it's also multiple different regions from coast to coast. Next, please. And what we've been doing over the past year or so has been kind of around these three themes with different amounts of emphasis. Next, please. So first is that COVID has been front and center on everybody's mind, and especially all the doctors. And so what we've been doing for the MARAC, first under the leadership of Dr. Barry and Miriam, who's Chief Medical Officer before me, organized and ramped up activity like crazy. So previously, the MARAC had only met maybe once a year. But as COVID hit and we were trying to figure out what to do, it all of a sudden became a weekly meeting. And like I said, this includes Lebanon and Ghana and Italy and every place else. What we tried to do was to understand the impact of COVID on individuals with sickle cell disease, because we're really, really worried that the unfortunate overlap of these two disease conditions would be really horrible. If you think about it, COVID affects lungs, inflammation, can put people in the intensive care unit. Sickle cell disease involves inflammation, can involve lungs, can put people in the intensive care unit. And so at the onset of this really bad disease, MARAC was extremely worried that if there was an individual with sickle cell disease who caught COVID, caught coronavirus and developed COVID, that would be just really bad, really severe, and it would be requiring very special management or precautions. So we met weekly to figure out what to do. And part of that impetus was, COVID started in China, where there really is no sickle cell. Maybe there's 2 people with sickle cell disease in all of China. So all the publications that were describing COVID in the early weeks had nothing that could give us any grasp on what would happen with a person with sickle cell disease, because there were none in those publications. So as we saw COVID starting to hit Italy and London, France, and then later move to the US, we wanted to get as many people aware as early as possible so that they could make appropriate precautions, advise patients in a suitable way, and really understand the latest things before it even came out as a publication. So that was really what drove a lot of these weekly meetings. And we were just exchanging ideas, trying to figure out what to do, but at the same time, trying to be really, I would say, careful and try not to go and be the first ones to say something in case we were wrong, but try to be saying things that were trustworthy. And so this was a huge effort of consensus building with 34 people, all doctors and experts, trying to exchange experience and trying to come to consensus. And that's what that check mark means, is that Dr. and Miriam actually got consensus on many, many, many things while on teleconferences. Next, please. The output from these consensus things was advisory statements for patients, shown in the orange there, that there were what kinds of things to do as precautions for individuals with sickle cell disease and their families to take. This was made first as a broad general statement. It was translated into a couple different languages. There was also an African version written, still in English, but adapted to the realities of the African medical system and African societies situations compared to Europe or North America. We had advisory statements about COVID and behavioral health, about COVID and return to school, about COVID vaccines. We strongly, strongly recommend that individuals with sickle cell disease get vaccinated against COVID. And neutralizing monoclonal antibodies was the latest one, which basically came out about last week. We tried to also disseminate this information, spread the word by online talks. You know, I wasn't about to tell people to be socially isolated and then go hopping on a plane and meeting with people in person. So everything was online. So I got to use multiple different Zoom and webinar and all kinds of stuff to try to do online presentations with Q&A sessions, sometimes in a town hall format, sometimes webinar. And my peers did like podcasts. There were other kinds of ways of getting the word out. And finally, we kept on exchanging experience in the green box there with each other and tried to write some advisory statements kind of for our other peers, the ones who weren't on the MARAC committee, but are also taking care of large numbers of individuals with sickle cell disease, to say, here's what probably is the most trustworthy consensus opinions. And this was coming out before many publications came out. And then as publications were starting to roll out, we were trying to make sense of the different reports from different places. Sickle cell disease is still, you know, in the world of COVID, sickle cell disease still is a rare disease condition. And so there are not large series of thousands and thousands of people with sickle cell disease and what happens to them with COVID. We're blessed that most of the people with sickle cell disease did a great job avoiding COVID, stayed isolated, took precautions and things like that. But the ones who did get COVID, we saw reports coming from different places, and we tried to put the information together for our colleagues in the front lines of taking care of individuals with sickle cell disease. Next, please. So that has been a huge amount of work by the Medical and Research Advisory Committee, MARAC. And we recently ramped down a notch from every week meetings to every other week, but still having tons of emails all the time. And again, these are all volunteers, so we're getting stuff continually like, oh, I'm busy this week taking care of patients. I'm sorry for the delay in answering. And then we also have things sometimes pinging around through different time zones in a 24-hour cycle, from Lebanon to Italy to London to Rio de Janeiro to New York, and then to California, and then back around the world again. Sometimes we get questions like this. And so occasionally I'll be answering individuals' questions if they're not like for your own personal medical care. Sickle cell disease doesn't right now fall under the guidelines for third COVID vaccine, and doesn't matter if the individual is on hydroxyurea. So wrote back an email to this individual, and I think we should try to get it published somehow on our website, that if you have hydroxyurea that's dosed correctly for sickle cell disease, it does not cause you to be immune suppressed. It's not like chemotherapy for cancer, because the dose used for hydroxyurea in sickle cell is just trying to bring things down to a more normal level of inflammation. In sickle cell disease, the inflammation is kind of up near the ceiling, really high inflammation. And so being on hydroxyurea brings it down to a more regular type of level, but does not make you immunosuppressed. So the hydroxyurea does not cause you to have a different risk level for COVID vaccines, the way that somebody else who is on immunosuppression for organ transplant or lung transplants or something like that might have a really flat immune system. And then the second point is that the list of conditions that make a person eligible for the third dose of vaccine is a very much moving target. I wrote this statement like a couple days ago, and as of that time, the Centers for Disease Control does not include sickle cell disease in the list of who's eligible for third dose vaccine. The American Society of Hematology kind of does. So right now we are not really recommending that individuals with sickle cell have to get the third dose of vaccine. I think you can if you can persuade somebody to do it, because at least one set of experts is leaning in that direction. We're waiting for more word from policymakers about who should get third dose of vaccine. And probably in the next few weeks, more and more Americans will be put on that list. As you may know, there's also equity discussions about how come Americans are going to get 3 doses of vaccine and other parts of the world haven't even gotten their first one yet. And so I have my feelings about that. And that's part of why I'm saying we're not in a rush to say everybody with sickle cell disease has to get that third dose. It's not completely clear that you have to. Next, please. One of the other areas that the MARAC is working on, that is shifting gears away from COVID, is the area of newborn screening. As people probably know, newborn screening is basically the way that people with sickle cell disease are getting diagnosed in the United States since about 1990. All 50 states are doing newborn screening that includes hemoglobin, and so that there's newborn screening diagnosis of sickle cell disease. And that's really the way that we find out who needs to be getting education about sickle cell, who needs to get prophylactic penicillin, who needs to get plugged into sickle cell care. But what about those with sickle trait? In some way, sickle trait has been neglected, but as part of the mission statement for SCDAA too. So sickle cell trait in many textbooks is called an asymptomatic carrier state, meaning it doesn't really affect you in any way that you're going to have problems. That is mild protection of against fatal malaria. I'll say that again, messed it up. Sickle trait in many textbooks is just called a no symptom carrier state that is mild protection against fatal malaria. And then the textbook would say, mainly what you want to do is counsel people about their genetic risk of having a kid with sickle cell disease if you, with sickle trait, have a mate who has also got sickle trait or some other abnormal hemoglobin. And that's pretty much been the thing that's been done with newborn screening, that this is considered sort of a byproduct result of the newborn screening program, that really you're interested in the newborn screening to find the disease, and that you have somebody for trait. Well, some states, they say you really have to do this and this. Other states even send out workers to the home to find the person if they have sickle trait, a baby with sickle trait, and have them come in for counseling. Other states, not so much. And so you have many people who had a newborn screen result in their baby and they never found it out, or it was optional or something like that. Now, this pie chart shows that in all the people with newborn screening, if you imagine, this is just an imaginary graph, it's not real data, that if you had a whole circle of many, many, many babies who are at risk for sickle cell disease or at risk for sickle trait, the newborn screen comes back, and shown in the gray is a number of babies would have sickle trait. Shown in the orange, orange is other abnormal newborn screens. These would be people who don't have any hemoglobin problem, but have other things found with their newborn screen, like hearing deficit or heart problems or a metabolic problem. And then you have those with sickle cell disease shown in this sort of golden color on that pie chart. And you may not be able to see it at all because it's a very narrow little slice. So that sickle cell disease, again, a rare condition, but if you compare the number of people who have babies with sickle trait versus those with sickle cell disease, it's a lot more who have babies with sickle trait. So right now, we have the potential to have some benefit for all these babies with sickle trait, for all the people, adults and young adults with sickle trait that they'll grow up to be. But the needs of individuals with sickle cell disease are competing for attention with the sickle trait. So what are we going to do? Next, please. There's new research now, actually, that shows we do have to think about sickle trait, that it has some health risks, not night and day type of health risk, but some increased chances for clots, for kidney problems, for other kinds of issues. And there's new screenings of sickle trait that are being mandated for student athletes, mandated for military recruits. This is bringing stigma and concern about things like heat stroke. CDC, Centers for Disease Control, actually made an educational bundle called the Sickle Trait Toolkit, which is an excellent thing. But it's on a website and not everybody's aware of it or talking about it. And it's quite a large toolkit. So I have trouble handing it all out or getting people to look through everything. There's like 10 things to click on. But with all this, in 2020, during COVID, the National Academy of Science Science, Engineering, and Medicine made a report on sickle cell called Blueprint for Action. And one of the things in their Blueprint for Action is a call for standardized communication of sickle trait status in genetic counseling and making mechanisms for making sure that people know about their sickle trait across their lifespan, including when they're getting ready to have babies themselves, and ensuring access to needed support and services. And MARAC is trying to help answer this call from the NASM report. This NASM report just came out about a year ago, and we're mobilizing the response in the midst of what to do with COVID. Stay tuned for more action there. Next, please. Clinical trials. So MARAC has also been paying attention to clinical trials. And one of the things is, again, trying to have trustworthy information. During COVID, you may have seen or noticed that some of the gene therapy clinical trials had been put on pause because of 2 people who developed acute myelocytic leukemia, AML, while in the follow-up period after their gene therapy for sickle cell disease. And MARAC met with the gene therapy clinical trial sponsors multiple times, multiple meetings, eventually released some consensus advisory statements for information for the community about the very confusing information that was coming out. Held a town hall meeting about the gene therapy with expert panelists, also with individuals with sickle cell disease who'd had gene therapy, who were thinking about it, et cetera. And overall, MARAC, I think we made some contribution. I don't think it was the thing that made any huge difference in the gene therapy efforts, but at least it provided some balanced expert opinion statements to what was coming from sponsors only, the regulators, the people who were conducting the gene therapy. So MARAC was trying to provide some additional voice that was relatively objective and trying to encourage transparent communication about clinical trials. And at the same time, really trying to encourage individuals with sickle cell to participate in clinical trials, but with some sense that many people are watching out for your well-being, your welfare, including Sickle Cell Disease Association of America through MARAC. Next, please. There's also, kind of related to clinical trial, there's registries for sickle cell disease being formed. And many of these are popping up now. Individuals with sickle cell may be asked, to sign up for this one. And then a couple months later, sign up for another one, and then another one. And so overall, MARAC is encouraging unified efforts. So you don't have duplication, overlap, competition. In the meantime, it is generally a good thing to sign up for these surveillance things, to sign up, stand up and be counted, better than hunkering down and not getting counted. So stay tuned on this one too, but we are trying to get unified on this. Next, please. And so in summary, SCDAA MARAC is a group that has 34 volunteers contributing their expertise on a regular basis. I forgot to mention these are fairly senior people, all of them. And so overall, I think there's like 1,000 person years of experience taking care of individuals with sickle cell in this group. We're watching COVID, trying to give trustworthy advice. We're watching clinical trials, trying to give trustworthy advice. And we're responding to the NASM report call about your push to sickle cell trait. And through this all, hopefully providing a useful service to the community through SCDAA. I think that's it. Thank you.
Thank you, Ms. Beverly. Thank you, Dr. Sue. That was an amazing information to bring back to the community. There's so many things, you know, being a leader in this community, one of the things that I have found by not just being a leader, but also being a caregiver of a son with sickle cell is that there's so many things happening in the background that we never know about as patients and caregivers in the community. And so one of the things that the Sickle Cell Foundation of Minnesota is committed to doing is how do we translate what's going on in the boardroom to the front rooms, to the emergency rooms, to the living rooms, right? To make sure that though we may not, it may not always feel like we're making huge strides, that we recognize these baby steps that are being made that really is impacting the trajectory of our future down the road. And it's also what I often call the time of planting is never the time of harvest. And so we have to continue to plant. We have to continue to water. I appreciate that much of your slides, Dr. Sue, had to do with COVID and everything that's happening around the vaccines and the outcomes for individuals with sickle cell disease. And so we know that it's listed on the CDC website as a condition that has worse outcomes. We heard you say in your presentation that right now it is not on the list for a third vaccine. And I also appreciate that you, brought up the fact that, equitable distribution of the vaccine is not just about Americans, it's about worldwide distributions. And those who are even worse off than those who are bad off in America, right? We don't oftentimes think of that in terms of outside of our Americanized privilege. And so the third vaccine that will typically be or likely be recommended for individuals with sickle cell disease. Do we think, and you may or may not have an answer for this, but do we think that that also applies to individuals with sickle cell trait? Is there any evidence yet that would say that they are more or less vulnerable based on just even having trait? We know that they are having disease. Anything that we can add to that conversation?
Yeah, that is a really complicated question. So right now, the information about sickle trait and COVID is still coming from multiple different directions. And the data, frankly, has slightly different answers. So I am not completely sure that individuals with sickle trait have higher chances of problems than the general population. The thing that probably will show up is that there is this thing where individuals with sickle trait have higher chances of kidney problems and slightly higher chances of clots. These are not night and day differences. These are like percentage differences, 10%, 20%, things like that. Not like double or triple those sorts of numbers. So if you have sickle trait and you have kidney problems, or if you've already had clots, then that probably does set you up for more problems. Does it mean that you have to rush out and get the third dose of vaccine today? Not sure about that. If you do have kidney problems, that probably does justify getting a third dose on that alone, and not so much the sickle trait part. So that was a kind of waffle answer.
No, I actually think that it's important that you're bringing that up, because really what that means is, first and foremost, if you haven't gotten your first shot, we're going to encourage you to get your first shot before we can even get you to your third shot, right? And so that brings into the conversation, as a person living with sickle cell trait, we do know there's a little bit more evidence that's coming to light regarding some of the organ function that can not always, but can be a part of living with sickle cell trait. And so it really does pull a bigger and broader piece of the community into this conversation by saying some of these underlying conditions that may not have been talked about as what's contributing to the underlying condition are some of the reasons and rationales why there is encouragement to get the vaccine in the first place. So I can appreciate that. And the other piece that your answer brings to light again is the importance of research, the importance of data collection. Both you and Ms. Beverley talked about some of the work that SCDAA is doing legislatively, as well as what MARAC is doing. And it all revolves around data. It all revolves around this participation of the community, because data doesn't always just fall out of the sky. It's because that there are people who are participating in order to be able to collect the data. I thoroughly believe that we get better results when we are creating things that are for us, with us, or at minimum not without us.
Right.
And so we can't show up after the fact and say, hey, how come we're not, they didn't call out this and they didn't talk about that, and how come that we don't know more about how it's affecting us in this area? Well, we have to participate so that we can get to those results. So I appreciate you bringing that out. And in fact, that's part of the question that I was going to, the next question I was going to ask you, and that is, when we use the term public health, that term has been used over the last year more now than ever. When we think about public health, what does that mean as a whole? We know our individual health, but public health is really bigger than just self. Can you speak to that a bit?
Yeah, that's a great question. And I acknowledge that I'm not a public health expert, but in some way, all doctors are trying to promote the idea of what public health is. And basically, it's the idea that there's things having to do with your health that come from outside of your skin, and outside of just you. So it's what you're breathing, what you're eating. Is your spinach contaminated with bacteria and you need to wash it? Is your air contaminated with smoke and you need to be careful about it, or eliminate the smoke, or get away from the smoke? Or is your air contaminated with aerosolized little droplet particles that carry COVID? So those are the things having to do with public health. The main hope is that there's information and scientific data so that you actually collect information that makes it reliable and makes you have a good reason for changing your behavior, turning your life upside down, or being afraid or not being afraid, based on some reasonable thing, as opposed to, I heard it from my friend's barber's cousin's aunt, that there is this thing you got to do, and turn my life upside down based upon that reliable source.
That's an excellent response. And we are not just, we are a sub community within a much broader world, right? And so we have to make sure that we are talking about how our community fits into a broader landscape, and how we have a shared responsibility over the health of ourselves, our households, our neighbors, and our bigger community and our world. So thank you. That I can really appreciate that lens for public health and maintaining that safety and the behavioral aspects of public health. What do we need to do differently different in order to get different results. So as having that lens of public health, you know, Miss Beverley, do you see sickle cell disease as a public health emergency? And then if so, how does, you know, you outlined beautifully all of the goals of SCDAA and where SCDAA fits into this national perspective. From a public health and even health equity perspective, is there anything else that you can say about how SCDAA is addressing these things from a national perspective in some of its own advocacy efforts?
Thank you, Ray. I would say yes. Sickle cell disease is a public health emergency, if you will. I know that across the country, the disparities among individuals living with sickle cell disease are stark. And I think there are sometimes assumptions made that if you live in urban areas, you don't have any disparities, or that everything is fine. And we're finding that the disparities are actually very real for families, which were highlighted during the 2020 COVID pandemic arena. I know that we had a number of individuals living with sickle cell disease and their families depending on technology, because, you know, schools were closed, the families were having to resort to working from home. And in some instances, there was one laptop or one computer or no computer. We had families who didn't even have the bandwidth to access technology. And we saw the emergence of telehealth and telemedicine being even more important for families who didn't want to travel and shouldn't be traveling to their providers' offices. And we know that there were some patients who were very hesitant initially about even doing telehealth or telemedicine because they weren't certain about what that meant. So yes, and I think transportation as one of the social determinants of health also brings about increased anxieties and stress. I live in Maryland and I see daily that there are families who are having to take 2 or 3 buses to get to a medical facility, and that sometimes equates to hours. And when you're taking children, small children along with you on that journey, just imagine what that looks like, and then having to repeat that journey on the way home. SCDAA has been involved, I think, through our member organizations in trying to get an understanding of what's really happening on the ground, especially during the COVID pandemic. And a lot of that information was also being shared with our MARAC committee so that they could respond in kind to what patients and individuals and families were sharing that they were concerned about.
Well, I think that that's awesome because, you know, what you're really talking about is hierarchy of needs, right? How do families focus on their healthcare needs if their basic needs are not being met? And so, you know, we at the Sickle Cell Foundation of Minnesota are also a partner organization with, and proudly a partner organization with SCDAA. We were a recipient of one of those mini grants last year for COVID. We were able to translate those dollars into assisting families with all of those things that you talked about, those concrete needs, right? Food and shelter, but it also was technology. It was also technology to ensure that their children could continue to be educated, but also so that they or their children could continue to seek medical care through virtual appointments. And so to your point, those are very real needs. And we lose ground very quickly when we're not meeting those needs and it's being overshadowed by something else. So we cannot forget that in order to improve outcomes in sickle cell, you also have to improve outcomes in just day-to-day basic needs and living. And so I appreciate all that SCDAA is doing and has done in the past, and all that you are working on doing. I am so thrilled about that 2020 NASM report. I think that it truly gives a blueprint. I mean, they gave it the right words, right?
Yes.
Words matter. That blueprint for outlining what the issues are. But once they outline that, then they spent the bulk of that talking about the solutions. I'm a solution-oriented person. And so it's okay. We have to identify the problem, but then let's put our energy into finding the solutions. And so I'm so thankful for that. I'm thankful that as a trait carrier myself, that there is more attention being given to sickle cell trait. And so we look forward to that. We want to remind our Minnesota neighbors that if you are struggling with any of those basic needs that we discussed, if transportation is an issue, if rent and utilities and food is an issue, please connect with us, contact us. You can reach us through our website, sicklecellmn.org. That's where we recommend that you contact us. We have many social media platforms, and unfortunately, we just don't have the staff to respond in timely manners if you contact us via social media. However, we also invite you to continue to stay tuned to our Living Sickle Smart series. As I said, this month, the month of September, Sickle Cell Awareness Month, there are a number of wonderful organizations doing lots of great events and education seminars. I would be remiss to also not bring up the fact that Sickle Cell Awareness Month is another wonderful time to talk about the importance of donating blood. I want to give a shout out to the Red Cross, who is going above and beyond to make sure that they are integrating themselves into Black and Brown communities, so that not only are they speaking and encouraging people to show up to donate blood, but they are showing up in our community to say, here we are, how can we help? What can we do? Not just how can you help us to make sure we have enough blood on the shelves, but how can we help to make sure that your community has what it needs so that it can show up. So that's what these great partnerships look like. I want to also shout out Be the Match. Be the Match is also going above and beyond the last couple of years in their efforts to really identify the needs of the sickle cell community and fit into those gaps where they can, because the need for blood and the need for Black and Brown donors on the registry for Be the Match is critical to improving outcomes. And next month in October, our Living Sickle Smart series will focus on treatments for sickle cell as well as curative therapies. And so all of that falls into that category as well. So stay tuned. Thank you, Ms. Beverley Francis-Gibson, President of SCDAA. Thank you, Dr. Lewis Sue, as the medical director of the MARAC board at SCDAA, as well as your work at the University of Illinois, Chicago in the pediatrics department. We are so grateful. This community, it takes a village. None of us can shoulder the burden of the work that's behind us, in front of us, or ahead of us alone. And so we must link arms. It's not about independence, it's about interdependence, so that we are stronger together and we can elevate our voices together. So thank you for joining us for this session, and we look forward to seeing you again. Thank you so much.
Thank you so much, Ray, for having
day.
us.
Thank you.
Thank you.
Bye-bye.